Forget about the infection. Nobody is allowed to use the word infection in my clinic.
Meet Dr. David Palombo, an internationally recognized EFP board-certified specialist in periodontology and implants. Known for his expertise in microsurgical techniques and tissue regeneration. With a passion for advancing periodontal and implant care, Dr. Palombo combines cutting-edge science with precision surgical skills to transform smiles and improve long-term oral health.
They are maintaining the disease. This is absolutely the worst thing that you can do, and this is not ethical in my mind. I have seen a lot of patients telling me, I've been paying every 3 months for the last 10 years, and now you're telling me that I'm looking towards a super complex treatment plan. There is a giant elephant in the room. How do you establish your relationship with your patient?
Why do you think periodontal disease is often misunderstood, not just by patients and also by many dentists?
I love your questions, honestly.
Thank you, Professor David Palombo. Welcome to Malaysia and welcome to our podcast. And it's been such an honor to have you here and to be able to share your experience. So for those who do not really know you, can you give a brief about yourself, your history, and what do you specialize in, and what are your pet interests of what you do now?
Of course. Thank you. Thank you very much for having me. It's such a great pleasure to be here with you today, guys. Well, basically, I am a dentist, as probably everybody else listening today. And I had quite of a diverse training, I'd say. I started as an oral surgeon, trainee under my first mentor, who's been Matteo Chiapasco in Milan, Italy. He is a very, very skilled maxillofacial surgeon. And at the very beginning, I was very fascinated about big surgeries, big flaps, big bone reconstructions.
Blood flying everywhere.
Orthodontic surgery, exactly, stuff like that. And it was very, very fascinating for a 22, 23-year-old dental school student to just shadow those procedures. And for a while, I tried to become a maxillofacial surgeon, to switch from dentistry to medical school. And I spent some time in the US trying to do maxillofacial surgery in the US. But in the end, it started with implants.
Okay.
I got so much passionate about soft tissues because I was feeling there was some missing link in the whole treatment workflow, from the bone reconstruction to the implant placement to the prosthesis. When I was at the end of my dental training, I really got passionate about soft tissues around implants. And I started digging a little bit, and I met Giovanni Zucchelli. And basically, I decided to spend a couple of years with him in Bologna. Just after my graduation from the University of Milan, he started his first international master degree. It was a part-time master. It was very well thought out because you could basically present the surgeries that you were doing in your own clinic, and he was supervising the vast majority of the cases. And you got beautiful feedbacks. And I fell in love with periodontology. I didn't know what periodontology was before. Basically, I transitioned from surgery to perio because of peri-implant soft tissues. And in the process, I discovered that there is a beautiful discipline that I was completely missing out. That is perio, that is saving teeth.
That's right.
And it is changing literally patient's life when you identify such a complex disease that can completely change somebody's life, for sure. And that was the moment where I decided that I wanted to go probably to the best perio school that there is right now, that is the University of Madrid under Mariano Sanz, who's been my third mentor. So after that transitioning phase, I chose to move everything to Spain. And I lived in Spain for almost 9 years, between going a little bit back and forth and staying whole time when I was a resident. And I took my master degree there, my EFP accredited master. And a month ago, I just finished my PhD.
Congratulations.
So I'm finally, thank you.
So I addressed him correctly as prof.
Well, prof. I'm not a professor, but I'm a doctor.
Well, yeah, that's true, a doctor. Well, on your website, It's such an impressive journey that you've gone through, and the mentors that you have, it's to die for. Any one of us as dentists would have loved to be with them. On this impressive journey, what made you go through and decided that microsurgery approach, which is what you preach and what you're famous for, and what drew you into this approach? Yeah.
Well, thank you. That's a very interesting question. And I'd say that none of my mentors actually are microsurgeons.
Yes.
Yet somehow I got very much into this. When I was at the beginning of my postgraduate training in Madrid, I was just looking a lot of videos online of people using the microscope. I got very much into Rino Burkhardt's material, for example, and of course Otto Zur and Marco Surzeler. And when I was at the University of Bologna, I met a great surgeon, and his name is Venceslav Stankov, a Bulgarian guy, amazing surgeon. And he opened a big door for me because he was showing me all of these videos, amazing content.
Okay.
Everything was filmed with the microscope, and I was like, let's give it a shot. And funny story, we had a microscope. We still have a microscope at the Master in Madrid that nobody was using. I mean, it's a beautiful microscope. It's actually a CJ optic.
Yes.
And basically everybody was just saying, the microscope doesn't make any sense in perio. It's too complex. And some people used it just for a very small mucogingival surgery or an apicoectomy. But it was basically just lying there. So when I was in my second year of residency, I said, okay, let's give it a try. And I started just doing basically non-surgical therapy with the microscope.
Wow.
And a lot of people at the beginning were laughing at me, or like, no, coming back.
Wow.
And of course, I mean, I started using the microscope because I wanted to have a mean to document my cases with videos.
Because of the videos, yes.
And when I was shadowing my first master, for example, Professor Chiapasco, I was taking the videos all the time. So I was the tripod. No, there was no microscope. There was a camera, and I was the one holding the camera. And that has been a very instrumental experience for me.
Yeah, because you need to know where to zoom in and where to see.
And when you record, you start developing an eye for the video camera.
Yes.
And then the typical path was that I was recording the video, and Professor Chiapasco was telling me, okay, tomorrow morning, 7:30 a.m., I want the video mounted on my desk.
Oh my God. That's
so I was going through the video. But that was an incredible way of learning.
Yes.
Because I had to go through the video, look at all the surgical steps.
And also within 24
learn
hours,
how to mount
fresh.
The video and then deliver the video. So it helped a lot. But I didn't have a student for filming my own videos. I was a student by myself. Yes. So I said, okay, let's try using the microscope so that I can see exactly what I'm filming. And once again, I fell in love. Because just the capacity to see so much, to change the magnification all the time and to accommodate the magnification to what you're doing, it's incredible. And for me, there was no going back.
My goodness. That's so inspiring because it is not easy for people to understand. And as I told you, I had 1 week of microsurgery training, and I think we were struggling like crazy. But it opened up another way of seeing things. And I think in perio, it's how you see it, as well as implants, how you see it and how you treat as well, and how you execute your surgery.
And how you communicate both with other dentists and with patients. I mean, the people who do perio know very well that communication is the first problem that we have to solve in everyday practice.
Yes.
You will never succeed in perio if you're not able to emotionally involve your patient.
That's right.
In the issue, that it's maintaining a
behavioral change
level of dental cleaning. The microscope is a powerful tool because I can show my patient some calculus
through the
with
microscope.
20 times magnification, and that's scary. I mean, you take a look at some calculus on a 60, on a gigantic screen, and the patient reacts to that emotionally. And we hook them emotionally with that.
Yes.
And the patient many times can see it live because they have a specifically designed room with multiple screens around. So I can tell my patient, okay, look at the screen on your right. Ooh. You see this?
Yes.
This is calculus. This is where you're not using the floss properly, for example. And the patient sees live. And they interact a lot with that.
That's amazing. We have to learn this because we've been engaging into behavioral change and trying to explain to patients, and it's never the same until you blow it up, as you say.
Yes. My dental hygienists are starting to use the microscope a lot.
Wow.
Because it's a very powerful tool. You put a plaque disclosing agent in the patient's mouth, and then they see their mouth completely purple on a gigantic screen in front of them. It's very powerful. It's very powerful.
That's amazing. That's amazing. Okay. As a specialist that focuses on periodontics and implants, what would you find that is most rewarding and what is most challenging? Obviously, the two opposites that we need to know.
I think the answer is the same, actually. And it's probably when you realize that patients truly understand what you do. That's, for me, it's both the most challenging and the most rewarding part. I mean, the most rewarding part of my job for me is when the patient says, I don't want to look at it. If you say it's okay, I trust you. Because they truly perceive that level of attention to detail.
Yes.
And that level of professionalism that I think we're all basically looking towards to. And this is not easy. Because patients are getting, I don't know in KL, but in Milan, patients are getting more and more skeptical.
Yes, that's true.
They're getting more and more doubtful with respect to the treatments that we suggest.
That's true.
Of course, the internet has done a lot of good things, but also a lot of bad things, and artificial intelligence even more.
Yes.
And so we have to fight for that. But it's very rewarding when we truly understand that the patient says, okay, I put my trust on you, you are my doctor, and if you say so, I'm going to do these behavioral changes. And it's not that frequent, but we see that every day.
Yes.
Not only with plaque control, but, for example, smoking cessation.
Yeah, that's one of the hardest.
It's a huge topic. It's a huge topic, but it's very rewarding when we have some patient who said, you know what, I quit because of you.
That's true.
That's powerful.
That's very powerful. That's what we as periodontists all hope for, when we can actually change them. But it's so difficult sometimes, and it's that constant struggle that we have to deal with. So do you have a preference, because you've gone through and published so many articles as well as done research? How do you even find time to do academic and do research work and do clinical work? And is there a preference, or you love them all?
That's very hard to answer. I love clinical work. I love it, absolutely. But, and this is something that I learned from my mentor, from Professor Chiapasco, since the very beginning. The way you approach clinical work, if you are involved in education, it's completely different. Because you see...
That's a beautiful sentence.
Yeah, I mean...
I've got to remember that one.
It's so easy, because I am a second-generation dentist. So I've seen my father working every day for almost for the good part of the last 40 years, basically. And it's very easy to be dragged into routine.
Yes.
And it's boring.
Yes.
It is boring in the end. I mean,
and you do the same thing again and again and again.
Yeah, we're not discovering new stars. We are treating patients with gum disease in the vast majority of cases. So it can get boring and it can be very repetitive. But the thrill that you get from always trying to be on the edge of the new technique, of the new approach, of the study that you're going through, I think this is the primary reason why I wake up at morning. You know, it really makes you want to go to the clinic and say, okay, I'm going to do this novel approach. I'm going to change that incision. Maybe we're going to show this in the next Congress. It's much more exciting. It makes me feel as not just a dentist, I would say, which is nothing bad, of course, to be a dentist, but I think it helps to just keep your mind fresh.
No, I think you've got immense power to even change our industry and how we think about perio and how we think about implants, and that's why it makes life so much more meaningful when you do something like that. And I think you have to spread it, and you have to teach us, and we all have to learn. Yeah,
thank you.
I think that's important.
Thank you so much.
Okay, for the younger dentist listener, if they would like to learn what you do and the techniques that you use to treat periodontal disease as well as implants, how should they embark on this journey? And I think we were just discussing that. Other than listening to your lectures, is there a specific path, or can we attend courses done by you and hopefully Ancora in Paro, which is our training?
Of course.
With our centers, that you will be here as well to train a lot of the people here in Asia.
Absolutely.
Yeah, and but for the younger ones, what do you think is a good path? Because you did mention sometimes it's not good to throw them.
That's a very good question. If I have to say, before jumping into the pool of a hyper-specialistic path, become a good dentist. Because, one of the biggest limitations that we have is that we just see that square millimeter of gingiva and nothing else around it.
That's right.
And that's a huge problem, because patients do not come with a gingival problem. Patients come with a mouth.
That's right.
Or with a whole body. So I think that even if I'm not doing anything basically out of perio, implant, and oral surgery, you need to be able to do a good filling, to do good cavity diagnosis, to understand a little bit of occlusion, to understand a little bit of pros. If not, you're never going to succeed. And this is something that in the Perio program in Madrid, we stressed so much. Every Friday, we have treatment plan sessions where you have to stand up in front of the whole program with a tribunal of 3 professors. The pros, that's the very American model. I'm sure in Lama Linda you did the same.
And with pros and orthodontists, and then you get fired from left and right.
But that's humiliating sometimes, because you think you understood your case, and then you realize that you just saw a very small part of the whole complexity of the patient. But it's a true eye-opener, I think. And nowadays, we try to do this as much as possible. You need, before digging into your own specialty, you need to clear the patient for any other problem. Because the worst mistake you can make as a specialist is to say, okay, I did the most beautiful mucogingival surgery, and 3 millimeters away there was a cavity, and nobody is treated. And I've seen this. You see beautiful implants with beautiful gum grafts, and then there is a feeling that it's overhanging.
No, I think you're so right. You're so right. We have so many examples.
And after that, when you have a good foundation, you can have a great foundation with your undergraduate training and maybe a couple of courses just on general dentist and restorative. Then, of course, depending on the level of specialty that you want to achieve, I would suggest for sure either to go in a full-time program if you truly want to become a specialist. I think it makes a huge difference. I mean, if you just leave the experience of staying 3 years inside a bubble, because it is a bubble.
It is
a bubble. And your co-residents just talking about periodontology 24/7, sharing cases, the little competitive air that you breathe inside those rooms, it helps a lot. It makes you grow much faster. That for sure would be the path that I recommend. Just depending on your geographical location, of course, look at AAP accredited programs if you are in the US, look at EFP accredited programs if you are in Europe. Madrid, for sure, in my mind, it's an incredible school with a huge legacy, and I would strongly suggest that. And I'm very proud to see that some of my students who took some of my courses then chose to become EFP specialist, and that was very, very rewarding for me, because you truly see that after maybe a very short-term 3 months course, they truly fell in love with perio, and they said, okay, I want to make this the center of my work life. And for those who do not want to be a full-time specialist, of course, we have a very broad spectrum of educational activities, of continuum education events that you can attend. And microsurgery, in my mind, should be one of those. Maybe not the very first one that you take. I would save that when you are a little more of an intermediate surgeon, for sure. But definitely it's something that it's going to change the way you approach your everyday activity.
No, I think in summary, it's more important to ensure that you've got good basic training. And making sure that you get a proper framework of ensuring you get as good a mentor and spend as good of time with people around you that can teach you the topic. Very often nowadays, the young ones, they just want to attend what we call them instant noodle courses, where they just have 4 days and that's it. I can do implants. That's it. I can do surgery.
Yes.
That's it. I can do ortho. But I think we are living in this world now where we actually need to look at the patient as a whole rather than just one part, or learn a technique and apply it to all.
Absolutely. I think we lived a good decade where hyper specialism has been probably
pushed aside.
Yes, exactly. I think it's a proper expression.
Yes.
But we always have to remember, even as if you look at the business model of your clinic, I mean, patients do not come to you
Anymore.
because they want a microsurgical intervention on their gums.
Yeah.
They want to fix their problem.
Yes.
And many times their problem is a multidisciplinary problem.
Yeah.
So you absolutely need a multidisciplinary approach, even if you're a hyper specialist.
That's right. That's right.
And the worst thing in my mind as a businessman that you can do to a patient is misdiagnose some of his condition. And you see patients who invested a lot of time, a lot of energy, and this happens a lot with missed periodiagnosis. I mean, we've all seen those patients.
And over-treatment.
Yes, who said, okay, I've been in the clinic for years, I've done, 12 veneers, ortho, fillings, fillers.
And
now you tell me that I have to do period treatment. Okay, that moment, it's very easy to lose the patient confidence. And it's very easy that that patient is going to start looking around for another dentist, because it's like, you cannot miss that. So comprehensive diagnosis, I think it's something non-negotiable to be a good dentist overall. And maybe if you choose just to perform a specific type of intervention, I completely understand it. And I chose to do that, for example. But comprehensive diagnosis is something that you can't miss, even as a specialist.
No, I think you're so right, because with comprehensive diagnosis, even just simple perio charting, a lot of clinicians tend to avoid that because it takes time, or they don't have the right stuff, and it's so quick for them to just go in and
they
do a filling.
They don't even have the probe,
They don't even have the probe. That's right. They don't even have the probe. And I think the younger generation now, it's in a lot of the quick method of just trying to save time and get things fast. And I think comprehensive diagnosis, you can't do it in 5 minutes. There's no way.
Yes.
Yeah. No way. And I think we do need to emphasize on that, especially for perio. All right. Your research focuses on tissue regeneration, as well as peri-implant biology, and in relation to implant biology with the different implant neck profiles. Could you elaborate your findings? This is getting very technical, but I think it's very important for so many people that do implants now out. Be it GPs, be it specialists, a lot of us are still very confused.
Yes.
Because the literature goes left and it goes right. It depends on which camp you want to follow. And sometimes it just, it's of course it's situational based, but what did you find?
Well, thank you for the question. Actually, this could be the topic of a whole podcast, probably. But I think it's a very fascinating topic. Actually, it's the topic of my PhD, and you could have not pictured it better, because I think we are in the middle of a storm right now, research-wise. Basically, we're facing a time where we have a very classical approach to implant placement and to implant rehabilitation that looks for shallow pockets. And this is the very classic ITI philosophy that we all love very much as periodontists. So you place an implant as shallow as possible with a polished neck, with a divergent neck. Yeah. And some of my professors used to say, if I can probe it, I can clean it, And that's very, very standard and classical approach, and has been working fantastic for many years. Yes. But it entails a specific limitations that when you're lacking optimal amount of bone, this type of approach tends to have a little bit of a resorption path. Yes. And we've seen it all. Yeah. And now the big question that we have to raise is what happens when you have a little bit of rough surface exposed. Yeah. which has no bone-to-implant contact?
Yes.
What is the susceptibility to peri-implant diseases of that exposed surface? So over the last years, especially in the last decade, or with what someone has been calling the zero bone loss philosophy, we basically transitioned into a completely different approach, which is based on deepening the implant very much, creating a transmucosal path that is not divergent at all. It's very straight, it's very narrow. In some implant philosophy, it's even convergent. That basically tries to create a setting where even if you have a little bit of bone resorption, the implant surface is still exposed, completely protected by bone. But of course that the perioclassical approach is going to tell you, you can probe it, you can clean it. What happens when you deepen the implant so much? What happens when you create a transmucosal path in such a way that it preserves for sure tissue, but in case of contamination, it's not cleansable at all. And there is still not an answer. But what we basically tried to address with my PhD was the influence between the geometry of the transmucosal path and the establishment of the peri-implant mucosal seal.
Wow.
So we have seen some literature in the past from the late 90s, from the Berglund studies, where we see that if there is not enough space for the establishment of the peri-implant mucosal seal, what we used to call the biologic width, we have a compensatory bone remodeling.
That's true.
Our body eliminates a little bit of bone in order to create enough space for the soft tissue seal. And this is exactly what happens around teeth.
Yes.
If you go to the very classic Wilderman studies from the late 60s, they were raising a flap. They were just doing root scaling.
And then you get resorption.
And you get resorption because you remove the cementum on the supracrestal component. So your own body resorbs bone to expose new cementum to create the connective tissue attachment. Of course, around the implant, we do not have an attachment, but we have a seal. It's an epithelial seal, but we need to create enough soft tissue cuff to maintain that epithelial seal functional. So the question now is how the geometry of the transmucosal component can affect the marginal bone stability in the process of creating that cuff. That's what we have seen, especially in the very last study that has been published very recently in clinical implant dentistry and related research, is that when you use a convergent transmucosal profile, so a very narrow profile, when you leave more horizontal space for the establishment of the peri-implant soft tissues, we have less bone remodeling. We use the micro-CT apparatus, which is basically a super advanced CBCT that allows you to measure three-dimensionally the bone-to-implant contact.
Cool.
And in the very first millimeter of the implant surface, the bone-to-implant contact is 40% higher if you have a narrow transmucosal path as compared to a standard cylindrical one.
Because of the horizontal.
Exactly. So you basically, and this is the concept that I tried to introduce with the thesis, there is no such a thing as a biological width. There is probably a biological volume, which you can achieve in different ways. Maybe you can have a very wide emergence profile, and in that case, you need a longer and thicker tissue. Or you can have a very narrow emergence profile, and you can achieve the same amount of peri-implant soft tissue volume with a shorter distance and a thinner tissue. And I think this is just a very first step towards clinical research, evaluating in a very standardized scenario how different implants with different transmucosal profiles behave. And of course, there is not an answer yet, but my personal philosophy right now, it's a little bit in the middle. I do not like too extreme deepenings of the implant, but I have to say I like very much the one abutment, one time philosophy with a slightly subcrestal implant surface. I place the abutment immediately at the time of surgery. I create the perfect environment for the peri-implant soft tissue seal to occur, and I don't touch it anymore. So I'm basically placing tissue level implants, but in two components. And this is very versatile because you can apply that even in bone augmentation cases, a lot in immediate implants, which is something that I like very much too, because I think it provides to the patient a truly effective treatment in the patient eyes. And yes, that's basically a little bit just an introduction of
No,
a very long
it's a
topic.
humongous topic. And throughout my years in implant dentistry, because we were taught with immediate implants and we were taught bone level implants right at the beginning. And in those days, it was very much tissue level first.
Yes.
So, we've come back the last 10 years, experimenting up, down, further up, and we can't get the answer. So we can't wait for the research to really give us a firm answer. And I think you've just explained it, that what your preference is, and I'm so happy to hear that it's bone level, and
Thank you.
transmute those
Excellent.
at one time and get the tissue in there as not what everybody says. It has to be a vertical distance. In actual fact, there is a horizontal component.
Yes, absolutely. We have to think three-dimensionally in this case.
Yeah. Okay. As we're seeing new technologies, I mean, even with implants, they've evolved so much from 10 or even 5 years ago, and materials. What are your thoughts on the latest innovation in bone substitute materials and membranes? This applies to perio, this applies to implants, which is very much our surgical field. Are there any exciting new things that I'm quite sure every dentist is looking forward to with innovation?
Well, yeah, absolutely. We see new materials every single day,
Yes,
of
true.
course.
Yeah.
And my first attitude towards that is to be very careful. Because, the market has to play the game of the market many times. And we are treating patients.
Yes.
So it is very important to always rely on very reputable brands that have a strong scientific foundations, that have been involved for decades into creating that science, that knowledge.
Yeah.
Because
I think
if
decades
not,
is the word.
Yeah.
Decades is the word.
Absolutely. With that said, of course, you cannot just freeze yourself into what has been done for the last 20 years without any type of innovation, because we need to provide innovation, because it is a competitive market, and we need to provide patients with something that maybe 20 years ago was absolutely impossible. And an exceptional result 20 years ago, maybe today it's a mediocre result.
That's true.
For today's standards.
That's true.
So the type of biomaterials that we use have to accommodate that curve in the evolution of the performance of our treatment. In the last years, I've been playing a lot with a material that I know it's not available yet in Southeast Asia, which is the use of polynucleotides combined with hyaluronic acid.
Wow.
That's something extremely exciting.
Okay.
It's basically a novel technology that, it combines, of course, hyaluronic acid that we know very well. It's a potent healing stimulator, but with the specific use of this new ingredient. Polynucleotides basically are unpacked DNA material that it's ready to use for the replicating cells. They work in a very fascinating way. At the extracellular level, they basically simulate tissue damage. The presence of polynucleotides in the intercellular environment encourages cells to repair a tissue trauma.
Wow.
Because typically, when do we have disgorgement of genetic material extracellularly? When we have necrosis. When we have apoptosis, there is no disgorgement. So it triggers a series of extracellular pathways that typically increase mitotic activity of the cell.
Wow.
But at the same time, the most fascinating process, it's called the building block theory. Basically, if you provide a replicating cell, genetic material ready to use, already unpacked, the DNA polymerases already has the nucleosides to replicate the cell faster. And this is what we have been seeing in preclinical studies showing the effectiveness of these new materials.
Wow.
Of course, the evidence is not there
Yeah.
at a satisfactory level. So I have to contradict a little bit myself. And this is why I started saying you have to be careful,
Yes.
of course. I've been testing these materials for the good part of the last 4 years now.
Oh my God, that's a long time.
Yeah,
Oh,
and
new
we
material.
are working hard to produce some evidence. A little bit of evidence already came out,
Oh,
and
that's
the
cool.
results are very good. But in bone regeneration, this is something that is changing the way I work, especially in those gray areas where you are always in doubt whether taking the risk of placing a non-resorbable membrane,
That's
for
right.
example, or not. And you have like an angel and a devil on your two shoulders, and
you're trying
one
to
is
decide
saying,
whether to save or not to save.
Just use the resorbable one. No, you should put the non-resorbable one, and then you put the non-resorbable one, and you have an exposure or a complication
and
right before summer.
That's
maybe,
right.
You know, that's the
and just before you are about to go for holidays.
Exactly.
Always.
So this gray area, for me, it's a huge area of development. Because if you can increase the spectrum of applicability of purely resorbable membranes and purely resorbable materials, you make your life simpler and less stressful also for the patient. Of course, it doesn't mean that we're going to stop using blocks. It doesn't mean that we're going to stop using non-resorbable membranes because severe atrophies.
There's no way. We still have to use them.
We still need that. And we still need autogenous bone. I'm a huge autogenous bone user in specific indications.
Yes.
But you have to fulfill those indications. We have to truly understand, and this comes back to diagnosis. Proper diagnosis, proper material selection, proper treatment execution.
That's true.
And if we have something that allows us to broaden a little bit the spectrum of the easier materials, very welcome in my house.
Have you done much with stem cells?
Actually not, because in Europe we can't work with stem cells.
Okay.
Yeah.
Okay. We will have a private conversation on this.
We are doing in Madrid some studies in university environment, of course. I'm not specifically involved in those protocols, but we have very esteemed colleagues that are working on stem cells from the hip bone marrow, for example.
Yes.
And the results look quite promising.
Yes,
but
they do.
I am a big simplifier.
Yes.
And I don't know how many patients want to have their hip harvested with some cells. It's complex.
It's too much.
Of course, once again, indications. If this is something that you can do to avoid a huge calvaldial graft after a car crash, fantastic. In everyday applications that the typical periodontist deals with, I don't see such
It's a very small area.
Yes.
Yeah, it's very, very small area. I think what we deal with is one of the hardest tissue, if I were to say as periodontist to periodontist. I remember going through the program, the hardest tissue to grow is that cementum layer that we somehow, it's been decades or more than decades that all professors around the world are trying to find the magic bullet of how do we grow this cementum back, because that's the answer to a lot of periodontology. Well, implants might be different, but if we can save teeth, then we may not need implants so heavily. All right.
That will be the end of implantology if we know how to predictably reconstruct cementum.
We might get killed first before that happens. Coming towards the end, we would like to do a bit of public advocacy about periodontal disease, and I think we might start this section more for the public as well. Why do you think periodontal disease is often misunderstood, not just by patients and also by many dentists?
I love your questions, honestly. And another question that probably could be an entire podcast or a series of podcasts.
I only have this opportunity to catch you because you're wonderful in terms of your thinking process, and that's why I need to make sure we get this.
This is a topic that actually in our course that we do in Milan, we have a 4 modules perio course. We dedicate an entire day just to this topic.
Wow.
And the topic is communication. And in my mind, the gigantic problem, the single biggest problem that general dentists have when facing perio, it's not a technical issue. If you're able to do a beautiful filling, if you're able to do an endo of an upper molar, you are more than capable to do everything that is involved with perio. I mean, honestly, I don't think that from a hand dexterity standpoint, we are doing the most complex discipline as compared to other things that our colleagues in dentistry do, which are incredible. I mean, my endodontist does things, recuperating broken instruments that it's like, how do you do that?
How do you even see?
But there is a huge problem. There is a giant elephant in the room that is, how do you establish your relationship with your patient? And the vast majority of dentists are trained since the very beginning of dental practice to address the patient as problem fixer. the classic old drill, fill, and bill philosophy.
Yes.
You have a problem, you come to my office like this, and you
Yes.
say, I have a lot of pain in this tooth, I can't sleep. And I fix your problem with an endo, and I'm never going to see you again unless you have another problem.
That's true.
And this mentality,
Has to
it's
change.
a complete failure when you try to treat perio.
Yes.
And this is why dentists fail since the very beginning in establishing a proper relationship with the patient. And if you are not able to explain patients that they do not have a one-shot problem that requires a single-shot therapy,
Yep.
you're never going to succeed. So when we do first consultations, and I still do a lot of first consultations, 50% of my time is just speaking to patients.
Yes.
Literally.
Yes.
I spent 1 hour just
Minimum.
talking to the patient and explaining what is periodontitis.
Yes.
I don't do the periocharting anymore. I don't do the x-rays anymore. I'm trying to avoid also taking pictures, and I have people that do that for me.
Yes.
The entirety of the time that I dedicate to you in my visit is just talking and showing you stuff and opening your eyes. And we need to transition from a problem fixer mentality to a consulting mentality.
Yes.
We need to create a long-term relationship with
the
our
patient.
patient
Yeah.
that basically is based on the concept of alliance.
Yes.
You know, we are allies
Yeah.
in the treatment of a disease that is deeply embodied in their genetics and deeply embodied in their behaviors.
That's true.
So we can fix the behaviors, but we cannot fix the genetics.
Yeah.
And for too long, I think that perio has been described as an infectious disease.
Yeah.
And I always try to break that misconception.
Yes.
Forget about the infection. Nobody is allowed to use the word infection in my clinic because patients look at infections as a disease that you can treat
Yes.
with an antibiotic.
Yes. No,
I have
no,
the
no,
infection,
no, no.
you take the bacteria out of me, and I don't have the infection anymore.
Yes.
And every time I start talking to patients, the very first sentence is always the same. You have periodontitis. This is a disease that lies on a genetic predisposition where you create an excess of inflammation in response to bacteria.
Yeah.
Which is a complex sentence to understand. And then
Yes.
we try to break this sentence into the multiple concepts. And I always say to patients, everybody has bacteria in their mouth.
Yeah.
I have bacteria in their mouth. You have bacteria in their mouth.
Yeah.
And then I look at my assistant and I say, he has bacteria in his mouth. But we react in a different way
That's true.
to these bacteria. So what we need you to understand is that for your specific predisposition, you need a level of cleanliness, which is not normal. And this is another huge problem in communication. It is very hard to look a patient in the eye and tell him, you're not able to brush your teeth properly. Because patients,
You're not good enough, basically.
and you're telling them they're not good enough in doing something that culturally you
They
learn
do
when
every
you are
day.
4 years old.
Yes.
That your mama tells you when you are 4 years old, 5 years old.
Yeah, you
So
brush it yourself.
it can be insulting
Yes.
to some patients.
Yes,
So we need to be very careful to open their eyes to tell them that they're failing at something that is very basic in the lifestyle and the life routine of everyone. But they're not failing because they're incapable. They are failing because first, nobody told them before.
That's true.
And second, they needed to do it
Yeah.
at an extraordinary level.
Yeah.
I always tell my patient, because of your predisposition, you do not need ordinary cleanliness. You need extraordinary cleanliness. And we're going to fight for it for a very long time.
Yeah.
So if we go back to your question regarding young dentists seeking for education, for sure, take a course on communication.
Yeah, that's
You know?
that's one of the hardest topic.
Take a course, and you know, a lot of people don't want to talk about it because inevitably, sooner or later, there is also the money part.
Yes.
You start talking about how to make the patient accept the expenses that you have to cover, and how do you organize a system in which patient can afford to maintain their maintenance care.
Yeah.
And this is something that we have to talk about. I mean, there is a business component in this, and you have to structure it in a way that it's sustainable for your clinic.
Yeah.
A lot of dentists, they just do like this when it comes to perio because they say, okay, if you consider all the time that I have to invest in this, it's not sustainable. I just want to place veneers and it's much faster. But it's not being a doctor in my mind.
That's true.
And I am 100% convinced because I live out of this. 100% convinced that you can make it profitable in a very ethical way. A very ethical way.
True. Yeah.
But of course, you need to provide invaluable educational content to your patients. The same education that I do with dentists, I do it with patients. I educate patients every single day. And when patients understand the value of the information that you're providing, then they're willing, of course, to pay what you need them to pay to make this sustainable. This is, of course, a mutualistic relationship, but it can work. And it works in many practices. If you have the proper training. And it's not a hands training. It's a mind
communication.
Training.
It's a mind training. It's true. We spend a lot of time communicating and you don't get paid for it. But I always tell the younger ones, it's the only way you can invest in your career properly because the patients will remember you. We have patients come back 10 years later and said, she said this before and I didn't listen. I chose something cheaper, something easier, something faster. And now whatever she said, it's happening. And I think that brings value. And that's when you know that you've done well.
Yes,
it's
absolutely.
Not so much on financial.
One of the benchmarks of a successful clinic in my mind is not when you treat patients, is when you treat families.
Yes.
Because you say, okay, my mom's come here, my sister comes here, I come here, and you are part of the family.
That's true.
And
that's true.
you only achieve that when you build trust. And you only build trust when you have an ethical approach and you communicate in a proper way. And patients respond to that very well.
Yeah, that's true. And, there's so much more awareness with gum disease now compared to 10, 15 years ago. We're also getting the direct opposite that we're seeing, where dentists are not communicating and assuming there's periodontal disease and start periodontal treatment without even a periodontal charting and charging, tremendous amount just because we charge that way. So I think that's life. That's
absolutely.
life.
We've seen that there have been some scandals lately regarding this topic, and this is not the way it is supposed to be.
That's true. How do you think we can actually minimize dentists not realizing that there's perio and start doing restorations and patients not realizing, even though they've been to a dentist every 6 months. For example, a lot of patients come to our clinic and they say, I've been seeing dentists every 6 months and I've been so loyal to my dentist for 10, 15 years and nobody told me anything about gum disease, and now my teeth are all shaky and I can't even chew and I can't even function. And recently I had one that it's complete perioendo, and they're just trying to stick teeth to teeth to teeth to teeth next door, and and it's just causing it to fail again and again, and it's just amazing. And when you look at cases like that,
I'm very familiar, unfortunately, with this situation, and this opens a huge door with respect to the meaning of maintenance care, and this is something that the vast majority of general dentists or dentists without proper perio training, this is a typical mistake that everybody does. Even dental hygienists a lot. Oh, you have perio? So I'm going to see you every 3 months. It's like, what are you trying to maintain? Are you trying to maintain a disease?
Or you're trying to treat a person,
a healthy person that stays healthy. And thankfully, in the new classification, but mostly in the EFP, AAP approved clinical guideline, this is crystal clear. Maintenance care, which is supportive periodontal treatment now, it's not even maintenance care anymore. It's a specific platform. It's a custom-made suit that is designed to maintain a patient in health once health has been achieved with active periodontal treatment. So the problem that a huge amount of dentists do is that they don't know how to do active periodontal treatment. So they simply increase the frequency of maintenance. But they are maintaining the disease. They are slowly trying to maybe prevent a little bit of disease progression, but this is absolutely the worst thing that you can do. And this is not ethical in my mind, because I have seen a lot of patients telling me, I've been paying a lot of money every 3 months for the last 10 years. And now you're telling me that I'm looking towards a super complex treatment plan. So this is not ethical at all. What you have to do is have the courage to look the patient in his eyes and say, you have a huge problem. We're going to help you fix it, but you have a huge problem. And you need active therapy. And I always tell to my patients, after I explain everything, and we spend a huge amount of time exploring the concept of the periodontal pocket, I'm saying, you are not done until we have fixed all of your pockets. Because I want your mouth to be clean and cleansable. If your mouth is clean but is not cleansable, it's not healthy. I can clean it every single day. You can come here every other day, and we can give you a maintenance care, but that's not practical. But if your mouth it's clean, because we clean it perfectly, but it's not cleansable, and if you have pocket, it's not cleansable, you're never going to be autonomous in maintaining your mouth clean, which means you're never going to be autonomous in maintaining your mouth healthy. So this is the meaning of active periodontal treatment, and this is the point that the vast majority of people miss. So once we are out of pockets, your genetic is still there, you're still a perio patient, you are a perio patient for life. And this is why you need maintenance care. You need maintenance care. You need your personal trainer to maintain you fit over time. Because if your genetic says that you tend to grow a lot of weight very easily, maybe after you lost a lot of weight, you need a program that maintains you in the beautiful way that you have achieved. It's exactly the same thing. But you don't put an obese patient on salad without proper diagnosis, without a blood work, without training, without supervision, just because, if you eat salad, maybe you lose a little bit of weight. It's not going to solve the issue of a pathologically obese patient. It's exactly the same thing. You need a comprehensive treatment. You need to restore health, and then you introduce that. Of course, this is not a nice conversation. No, it's a very difficult conversation to have. It's very difficult because some patients do not react properly. But it's the only, in my mind, it's the honest conversation that you can have, because you have to be honest with your patient. And sometimes I have to say, I am so sorry. I don't know who treated you before. But you come to me and you're asking me for my professional opinion. This is what I see. And then you choose how you want to proceed. But this is what I see. And if you don't address this topic, we can't treat you. And we lost many patients. We lost many important patients, businessmen, super busy, 2 cell phones, private jet, stuff like that.
Everything instant.
Exactly. And they miss appointments. They don't listen to you. And they say, you know what? I've been to China the other day, and they can do it in an afternoon, you know? Literally, they told me that.
And for 1/10 of the price or something.
And I mean, sometimes it's not even a problem of price. It's just a problem of, to some people, everything has to be immediate. And it's not.
I think we live in this world now that is so scary, because everyone wants things fast, and they just forget the meaning of what we do in actual fact. This is why communication is so important. It doesn't matter who is your patient. You need the communication skills to tell them, listen to me, I understand you're a very busy person, but you have a problem. You choose how you want to deal with your own problem. And it's not my problem, it's your problem. That's true.
I'm just opening your eyes. I'm just here to explain you which type of problem you have, and you are completely free to choose how you want to address this problem.
True.
But
that's true.
I can tell you what works in my hand and in 45 years of literature.
More than almost 100 years now. Almost 100 years. But it's true. It's true. I think for patients, we often tell patients that the one thing you have to look out for, even just as a supportive or maintenance care, if you decide not to stay with us and go back to your dentist, we have to make sure that at least a bit of periodontal charting is done at once a year. You know? I mean, that's that's the charting business for a lot of patients. They think that you're probing their gums and it's painful, but it is so important, I think.
I always tell my patients, the period chart, it's my blood work.
Yes.
If I take a look at your blood work, I can see your cholesterol.
Yes.
I can see if your liver is good.
Yes.
I can see if your kidneys are good.
Yep.
You don't see it. And this is also another important topic. The fact that periodontitis is a silent disease.
Yes.
And I always tell my patients, if you go to your doctor and they tell you, you know that all the markers of liver health are completely off,
They will take things seriously.
you take it. But I don't see a bubble in my liver. I don't see any problem in my liver yet. I'm telling you that you risk a severe liver disease because I can see those markers. And the period chart is exactly the same. You don't see it. But if I'm telling you that you're probing 11 millimeters around that premolar, even if you don't feel any pain, you have to listen to me. And this is exactly the same thing. And exactly as any patient with a systemic disease once in a while has to do blood work, we need period probing. But yes, it's hard. I try to avoid being the one who probes, even for that matter. And I've experiencing that in my communication journey. If I just probed you, I'm the one who gave you a lot of pain. You don't want to listen to me in that specific moment emotionally, you know? And this is very important. So I try, for example, and I calibrated a lot with my 2 dental hygienists. I have 6 dental hygienists in the clinic, but the ones who probe reliably for me are just 2. And we did calibration sessions. We probed the same patients and we constantly compare, and I'm very trustworthy with their probing. I send it the patient to the dental hygienist. They do the probing and then they come back to me and I just talk to the patient. And that's the moment where we talk. And
it's different.
It sounds stupid, but
no, it's
it affects the psychology of the conversation.
That's true.
I think
that's true. We do the same here, where our general dentist probed and get everything ready before we even walked in, and so by the time we walked in, we are not the ones causing the pain.
Exactly.
It's easier to talk to them. Okay, coming to what everybody wants to know, especially for patients, the power of dental implants. We are at this day and age where social media is out there. What is the most fearful thing now? Because patients come in and say, no, I'm told this teeth cannot be safe, but we are periodontists, so we tend to try and save teeth, and we don't see the need for some of these teeth to be extracted. But nonetheless, they are told implants are more reliable than your own teeth, and things like that. So what are your thoughts, And if they want a dental implant, what advice do you have for your patient to ensure long-term health?
Well, that's another beautiful question that I think it links a lot with what we have been discussing through this time. And I think that the common element is always communication, once again, and culture, I would say. You need to provide proper culture with respect to taking care of your own oral health. And you can see this in a huge variety of different scenarios. Of course, you can buy a beautiful handmade custom suit that maybe it's a little more expensive, but will last forever.
Yes.
You can give it to your son,
in
30 years, and it's still going to look great. And of course, you're going to invest a little more money. It's going to take more time. It's not going to be ready in 1 hour. It maybe takes a month for the tailor to build it up, but it's going to last forever. Or you can go to a super fast fashion store, buy a €5 shirt, and after a couple of days in the washing machine, you have to throw it away and you have to pollute the whole environment, So I think that responsibility in the actions that we take, it's the common ground that should drive our decision-making process. And we have to be able to transmit that responsibility. Of course, if your only preoccupation is the numbers in your clinic, you can be very flexible with your diagnosis of a hopeless tooth, of an unsalvageable or terminal dentition. This is a term that I hate so much, terminal dentition. It's like, it's not terminal dentition. It's like a patient dying from cancer. All of a sudden, you call it terminal dentition. That doesn't make any sense. I always try to be very transparent with patients. Of course, if in my mind, a tooth, it's genuinely salvageable, I say, this tooth has to stay in your mouth. You want to take it out, you go in another place.
That's true.
Because if not, maybe one patient comes and say, okay, can you take away my right index finger? I don't like it anymore. Take it away. I will pay you. And no, it's patient mutilation. You know, you can't do that. Of course, there is a gray area. And the more perio-trained and endo-trained you are, the more the gray area can be flexible also in the other direction. And sometimes we are biased. Because I have to admit, sometimes I see an unsalvageable tooth and I say, oh, that would be the perfect case for the new Congress, you know, or for the new course.
To try and do this,
Yes. And my endodontist is like me. It's like we're constantly looking to the impossible case because we believe so much in this. And then patient selection. It's the utmost important factor. I will never suggest a complex treatment with low predictability to a patient that is not willing to take those risks.
That's
you
true.
have to understand who you're talking to. And sometimes
it's also the age of the patient.
And the mentality. Sometimes I have no shame in saying I extract potentially salvageable teeth if I'm treating a patient that since day one clearly is not going to understand what he has to do to save the tooth.
That's true.
Heavy smoker, poor plaque control, poor
Missing
compliance. I mean, emotionally, you do not connect. That's an important aspect. And sometimes you have a patient that lives in front of the clinic. He has no problem whatsoever to come multiple times, multiple revisions. He wants to try. He says, okay, it's my tooth. I want to try to save my tooth. And I will never say no. Unless it's a vertical fracture, I will never say no. I have many patients. I think if I take a look at the numbers in the clinic, the single procedure that I do the most is perioregeneration.
Wow, fantastic. Fantastic.
And perioregeneration, it's so rewarding for me because first, I'm saving teeth. And patients truly see the result. And there is a very interesting psychological phenomenon related to that, which is loss aversion bias. If you take a little bit a look into the psychological literature that there is, for example, behind trading. When you trade money, the amount of suffering that is caused by a loss, it's between 2 times and 3 times higher than the satisfaction that you get when you win. Let's say that we play a game now and you win $10.
That's good information.
Yes, that's something that we share a lot. And there is a lot of literature behind that. You win $10, you are happy. The amount of dopamine that you have in your brain, it's a certain amount. I take $10 away from you because I win. You suffer between 2 and 3 times more.
Wow.
And this is something that patients, you truly see that in patients.
Yes, true.
And periodontal regeneration, in my mind, is a perfect example of how to deal with loss aversion bias because the patient takes a look at the radiograph and you see the intrabony defect. And it looks so good on the radiograph because the patient sees, that's my bone that I lost. I lost my bone.
And then you grew it back.
I want my bone back, you know? And it's much more powerful in the patient mind to have something back that it was his and that some disease took it away, than adding something new. I have many patients that miss some molars and they got used to not having the molars, for example, and they're okay. But when you give the opportunity to give it back, they always want it. You know?
It's very different.
Yes, I think that's the single most important factor to try to identify the type of patient and to try to read the psychology of the patient. And if the patient doesn't care, it's okay. You have to understand. If the patient doesn't care, they don't care. And some patients still are perfectly happy with an extraction and a removable denture. It's something that I do not advocate. It's not fulfilling for me. It's not my treatment choice. But if you're treating a 98-year-old woman that has multiple diseases, that has, some maybe mental difficulties in understanding because they're very old, it's still something that you should consider to do.
That's true.
You have to tailor your treatment based on your patient's needs. And
I think the issue now is we're pulling teeth too fast because we think that implants are going to be the new thing that can replace it as if it's your own. But I think we do see enough complications now with implants.
Absolutely. There is way too overconfidence in the performance of implants. And there is not enough confidence in the preservance of teeth. And actually, we had a very nice opportunity in our group in Madrid when the clinical guideline for the treatment of stage 4 periodontitis was being developed by the EFP consensus. I was part of the group who did the literature review for prosthetic treatment in absence of implants.
Okay.
And we had to review all the classic literature from the 70s, mostly from the Swedish school, of huge bridges on just 4 or 3 dental abutments. And the dental abutment is like this short. And they had like 27-year-long follow-up. And it works. And my father has been doing this for a very long time, for example. He's a very traditional dentist, a very classic dentist. He puts some implants, but he has been around before implants were a thing, you know. And I've always seen many patients after 20 years, 25 years, where maybe you use the wisdom tooth as an abutment. And if you say something like that in a Congress podium right now,
we will get caught.
People are going to boo you, you know, but
that's true.
It can work fantastically. So
I think the basic of dentistry, like you say, we still have to respect that with good occlusion, everything well thought out, then it's possible that the prosthetic methods that we traditionally used to use, it's actually working for a lot of these patients. And they work far longer, because implants, for them to last 30 years, it's quite a challenge. We still don't have data on that at all, actually. I mean, we will get case reports, but we don't get long-term data.
And there is not a single implant on the market that has been completely unchanged in the last 30 years.
That's true.
So you can take a look at literature. We can produce all the literature that we want. But the fact is that teeth are always the same. And implants are constantly changing. For good, for sure. But we're lacking some data. And I think you need to give it a shot to teeth many times. And we go back to communication. I think the vast majority of dentists skip the treatment of the tooth and go directly to the implant, because they don't want to face the unpleasant conversation if something goes wrong. While if something goes wrong with the implant, you know, it's the implant. It's not me. I just placed the implant and the implant failed. If I give you a periregeneration and it fails, it's because of me. It's not because of the periregeneration concept. And this is something that has to be fixed with proper communication. Once again, the more I work in clinic, the more I understand that my main job is communicating. You know, I could stop doing the surgery, but I could not stop
talking to patients.
And
I think that's most rewarding as well, especially when you see their eyes sparkle, that they understand what you're saying, and they want to do what's best for them.
Absolutely,
that's the best thing. All right, one last question. What is the biggest misconception in social media platform now that worries you the most?
That's a very, very complex topic, because I'm heavily involved in social media, as you know, and I think it's a great tool. And I think it introduced a huge amount of positive changes in the market.
And as well as educating the public, which we will need to, because it's hard for every patient to get to see you.
Absolutely. And I think it's a very democratic way to provide education to dentists and patients, in the sense that in the classic system that we've been living in for many years, the academic system, the Congress system, of course, there is a path that you have to follow. And I've been very privileged. For example, I studied in a magnificent university in undergrad, and then I got the contact of a first mentor, and then a second mentor, and then a third mentor. But I understand that not everybody else had the same privileges.
That's true.
For a huge number of reasons. But social media puts everybody at the same level. You upload your content, and it's the quality of your content that decides if you succeed or not. Now, the problem is how we evaluate quality and how you structure your content to engage people. Because one thing is to be successful because of the quality of your work, and another thing is to be successful just because you create some specific content with the intent of capturing attention. And everybody is trying to capture everyone's attention. And that's sad. Because if you take a look at some of the things that are out there, and it's just
it's
an
misleading.
attempt to gain attention.
Yes.
Misleading.
Yes, it's misleading to patients, actually.
Doing informational terrorism a little bit, trying to scare people.
I like that term.
You know?
I like that term,
just to get the attention.
Yeah.
And you see it in our discipline
yes.
as much as in anything else. I don't know. I was coming to Malaysia and Indonesia for this trip. I was taking a look at my feed, and I was just bombarded with videos telling me to be super aware of any potential type of problem that you can encounter in Malaysia and Indonesia. And it's like, and it's not like that. I mean, I'm here, I'm
it's like
healthy.
We're super unsafe.
Yeah, but you know, how do you catch people's attention?
Yeah, that's true.
Talking about a huge problem that you can face.
Yeah, especially with news nowadays, you know.
Yes, and in our job, it's exactly the same. So I think that, as Bill Gates once said, content is king. And if you provide unavailable quality content, it's the content by itself it's gonna make you spark. It's gonna make you shine. If you try to shine just because of a little bit of, makeup, but the content is not there, sooner or later this is gonna crash. And it would be nice if patients had the tools to understand that. But unfortunately, many times they don't, because they do not have the tools, because they're not dentists.
That's true.
So there is a lot of sparkling out there that it's probably empty inside. And I hope that in the future, the market itself is going to select the people that are reliable sources of information. And we have a lot of incredible sources of information.
Yes.
Social media changed the way I work. Because I saw a lot of great people, and I got in contact with a lot of great people, and a lot of things that I do are thanks to social media. So we do not have to demonize social media at all. We need to understand how to use it in a responsible manner. It's literally like with anything else. You can use electricity in a very intelligent way, and or you can give fire to your own house. You know, it's a very powerful tool. We need to learn how to use it in a responsible manner in order to be successful.
Yeah, that's true. I think for the patients, I always tell them it's always good to get second opinion.
Yes,
you are free to come to us, and you're free to go somewhere else. But you need to understand the disease, and the internet provides good information and bad information, and you need to discern between them and read the messages carefully. I think that's one of the most important things.
Yes, and scientific societies in that manner can play a huge role.
And the right ones especially.
Yes,
and
they can be very reputable, and some of them, the European Federation of Periodontology, for example, in the Italian Society of Periodontology, where I'm involved heavily, we are doing a lot of work. The Spanish Society of Periodontology is doing a lot of work. We try
American
to do
Academy as well.
Yes, absolutely.
Do so much of public awareness.
We try to do some podcasts like this. Yes. We try to do some shorter content. We try to provide something that
allow patients,
general people can easily digest, and that it's provided in a very reputable format, in a reliable format.
That brings us to the end of this podcast, where the joy of providing the concept of doing this podcast was because I was inspired by one of the famous designer from Denmark, who actually was in the 1960s that wanted to develop and create a movement of bringing joy to everyone in life. And in the 60s, it was quite a difficult time and quite So I think dentistry is actually going through that because of digital technology, because of social media, and because of education that we do in this region. For the last 10 years, I felt that it was just not going the right way of where we wanted to do with dentistry. And that reminded me that we have to still believe that we can bring joy into everybody's life. And what we do is, that's why we've talked to optimists.
Oh, that's very nice.
To make every day a little bit more joyful. This is our small little gift for you.
Thank you.
He kind of bring joy to all of us. And everyone that's coming on to the podcast gets one of this. We talked to them and they
that's
were
very
so
nice,
happy.
very thoughtful.
Yeah, I mean, I can't believe this thing has been here for since 1960s. And it just, I hope you will remember us, and I will bring you back to Malaysia, and hopefully
Absolutely.
we will have to learn from you about microsurgery and regeneration and perio. This is always the tough part. I don't know how to take this out. It's secured so well, I know that. So
I think maybe just turn it around or like this.
Yes.
It's a small microsurgery.
Yeah. Oh. See, I've learned now you have to rotate it. The other day I just pulled it out.
Okay.
Yeah.
It's like this.
Yep.
Wow.
Yeah.
That's very nice.
So Optimist is supposed to bring joy to all of us, and that in this very confusing time of dentistry where there's so much going on and so much changing, we hope that what we do with the podcast is going to guide more dentists to do the right thing and more patients to get better care and to identify who are the good people in our industry and how we can help to create better work and better treatment care.
Thank you very much.
You're welcome.
It's a beautiful message. It's very enriching, absolutely, and I completely agree with you. And
yeah. Well, my son was quite funny. He goes, "Mommy, this is so cute." He goes, "If you are sad and you're unhappy, and when patients make you unhappy, this is what you do. Wow, 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 and make yourselves laugh." And I was laughing all the way. I say, I mean, the world has come to this stage where it's always about negativity. It's always about something is wrong, everything is not right. And this reminded me, hey, there's still a lot of good in dentistry. And there's still a lot of good. We need to do education.
Yeah, and I mean, I think people react to that.
Yes.
Very positive. If you bring positivity, you get back positivity. If you bring negativity, it's very hard to get back positivity.
It is.
In the end.
No, but he's amazing. He used I can't pronounce his last name, but he provided and designed this thing in the 60s. Oh. And it says it's not a toy. So my kids were very happy. Mommy, you didn't buy me a toy? It's not a toy? I say, no, it's not a toy.
It's serious stuff.
It's serious stuff. Like dentistry.
Exactly.
And microsurgery.
But it still can be fun.
Yeah, that's true. Which is so much fun. I see the way you do microsurgery, and I see the videos. I mean, online, you are in a zone where you're so passionate and you see the joy of what goes on.
Yes.
Yeah, and I think all of us should find that. And the minute we find that, that's when we do good for everyone.
Thank you. Thank you so much. Really appreciate it.
Yeah, thank you. Thank you for spending time with us on the first day.
Oh, my pleasure. Absolutely.
Yeah. Thank you again.
Thank you. Thank you so much.
You're welcome.
Once again.